even sustainability. Our work is going on, but there are challenges where we are supposed to go to the ground, especially in immunization. The static is going on very well, but the challenge comes when you are making follow-up to the community, when there's not that enough money to always go and check or follow up immunizations, so it becomes hard. We would only wish to have some support on increment of facilitation for those staffs who are responsible to go to the village. Maybe the VHT support down there should still stand. We do give them, we budget for them on the little resource we have, but it's not enough. Instead of making around 5 outreaches, we can make 2 or 3. So when we cut on those numbers, some villages are still going to be left out. Yeah. The Amref objective has really helped us in those communities they are in, because we have tried to scan out those communities that have not been reached well, like the hard to reach places, the communities that we are not ably assessing their facilities. So we are now following them up, supervise even at the posts where immunizations are taking place, even statics. We go into the data, there is also data team will go and supervise and see how good things are moving on. With that follow-up, it is improving in our immunization status in that district, at least for those affected communities where Amref is working. Yeah.
When you talk of the hard-to-reach places,
more communities where the health facilities are very far, they can't access it easily. Now, hard to reach in terms of service delivery, so they cannot access it easily. Somebody will wish to bring a child for immunization in the house, doesn't have money, and they are very poor communities where they cannot have transport to go to a facility. So it makes them miss opportunities to their children. Yeah.
How is the response?
We are trying to put in many involvement through community dialogues, but it is still a bit low. Many always are busy. They assume to be busy and not being part of. So they are very busy, but we always engage them. We engage them, male involvement in immunization, but some have started because when we go to such a community, we always organize a dialogue where some key men are there, and those key men can also send information for those who are there on the ground to follow their women.
What about the
We have antenatal cases is still very low. How we grade them? We have first antenatal, because we encourage mothers to visit the health facility at least 8 times. But normally the first trimester, the first 3 months is very hard to get. We are at Temuri. Okay, we are at 33%, first ANC, first trimester. And then when we follow 4th antenatal, we are at 48%, which is very, very low. It means we have 52% of our mothers, they don't get to 4th ANC. And first trimester is where the developmental stage of the children are. If a mother does not attend first ANC in the first trimester, this is where most babies can get deformities. Mothers can get malaria, and it affects the baby. When the fetus grows in the utero, these are the mothers who come with the dead fetus in the utero, fetal deaths at that middle age when they have not grown fully. So it is part of our perinatal mortality that is very high, caused by failure to treat infections within that range during antenatal. Because when mothers come to antenatal, we treat them for STIs, we check for HIV, we prevent them from getting malaria. we also prevent our babies from getting infections like HIV through giving them preventive treatments. So if these mothers don't attend in the first ANC and the consistent ANCs, that's where trouble comes. Most of our mothers come at the late stage because in the first trimester, mothers always hide to show that they are pregnant because they have fears. How will the co-wife see they are going to bewitch her? So how will I so that I'm pregnant yet I don't know what I have in me is a real baby or not? So they have those fears. So those challenges make them come very late in ANC, and they are the mothers who get problem in delivery. She can come when the baby is dead in utero. She will come late for even delivery because these messages are not given to her. Because if they come for antenatal, we give them packages on how to prepare for the delivery of the baby, what food to eat, how to prevent themselves from other diseases. We check for syphilis, we check for HIV, everything. We make sure the mother moves in pregnancy without any other sickness. Because when we give them disease, drugs which can prevent malaria, we have saved the baby and the mother. But at most in Mityana, we miss on that because first trimester we have very, very few. And the other challenge we have is when delivery. We are having screening of high-risk mothers, those mothers who deliver very many, past 6 babies. If a woman has delivered more than 6 babies, she's a high-risk mother. The uterus is already porous, it's very weak. Another consistent pregnant can rupture as it grows. There's that challenge of having TBAs in the communities. They mislead them, they hide, they don't come to the hospital. So they will come to the hospital when the TBA has failed, they will come very late just to die in the hospital. Like we lost a mother yesterday. She was 4 previous car. She had delivered, she cannot deliver normally. TBA told her, if you can come to my place, I give you drugs, you will deliver normal. She started laboring there, not until she reached the hospital when she was dying. There was nothing done. She died yesterday. So those are the cases we are getting. The high mortality rate is because of lack of understanding of how to come to get care from the facilities. And also, we have communities who are still not accepted to come to facilities to take care. And the males are not supporting the mothers. So mothers are getting pregnant, but the males are not, the husbands are not supporting the mothers. Till the delivery, she labors her own. And that's where they get issues. And also we have very high teenage pregnancy in the district, especially in Banda and secondary.
Banda.
Secondary and Malanga. We have very high teenage pregnancy. And also, because they hide a lot, they normally come to deliver when they have got issues. They don't come to antenatal. So we need now to have community dialogues in those spots where there are issues in the district, which is still lacking. So that's the plan of the district.
What is the cause of these teenage pregnancies in those areas?
No?
The cause of those teenage pregnancies in those communities, Banda, Malanga, and Sekane. Why is that?
There are so many factors leading to that. You know, this time it is the teenage, because there are so many dropouts, school dropouts are there, and also I think it is now the media, social media, whatever, which is misleading our young people. People no longer follow the culture. It was through the culture that people can be helped. Even the parents are not guiding their children so much. I think it is from the parents now. They are not telling them what is actually on the ground. They fear to tell them those crucial things of adolescence. I cannot tell you that you can now, when you meet with a man, you are going to get pregnant or fertility. Parents will never tell the child. Instead, will say, those ones who are like who are in school will go, the teachers will tell them. But those ones who are in the village, they suffer alone. Nobody tells them what to do. Yeah.